Blunt trauma. Mechanisms of blunt injury. We have two mechanisms of blunt injury, including direct tissue compression or coup injury and indirect disruption by the shock wave or contre-coup injury. In coup injury, there is tissue disruption at the site of impact, whereas tissue disruption in contre-coup injury is at a site opposite to the site of impact via force waves transmitted through the globe.
Mechanism of blunt trauma injury: compression, decompression, overshooting, and oscillations. Compression. Anteroposterior compression of the globe at the cornea results in equatorial expansion. Anteroposterior diameter decreases by 41%, leading to corneal lens iris touch. Equatorial diameter increases by 128%, with subsequent injury to the retina, vitreous, choroid, optic nerve, and lens. Effects of blunt trauma on the eyelids include ecchymosis, surgical emphysema, hematoma, black eye, ptosis, which could be mechanical or paralytic.
There may also be eyelid laceration as a result of the blunt trauma, where horizontal wounds result in better wound healing, but vertical wounds heal by fibrosis, resulting in eyelid anterior lamellar shortening. Wound healing. General aspects of wound healing. Wound healing aims at prompt restoration of the anatomic and functional integrity of the organ or tissue with scar tissue formation. Stages of wound healing include acute inflammatory phase, regeneration phase, and finally, contraction of scar tissue. Acute inflammatory phase. Tissue activators released following trauma result in blood clotting and chemotaxis. Regeneration phase. There is replacement of dead cells and repair, including reconstructuring or remodeling of tissue by granulation tissue that matures into fibrous scar. And as we said, finally, contraction of the scar tissue occurs. Eyelid skin wounds healing. Healing by first intention. It occurs in clean, uninfected surgical wounds that are approximated by surgical sutures. Surgical wounds induce minimal disruption in epithelial basement membrane continuity.
Within 24 to 48 hours, epithelial cells from wound edges migrate and proliferate over the dermis under the surface cap, depositing basement membrane. By day 3, macrophages and granulation tissue proliferate in the dermis. By day 5, angiogenesis is marked, with granulation tissue filling the incision space with collagen starting to bridge the incision. Surface epithelial cells grow into a mature architecture with surface keratin.
Suture removal at 1 week is associated with a wound strength of about 10% of healthy skin, which recovers quickly within next 4 weeks. By second week, collagen and fibroblast proliferation continues, inflammation decreases, and the scar becomes more white. By 1 month, the scar includes a cellular connective tissue with minimal inflammatory cells, with normal epidermal covering. Dermal appendages at site of incision are permanently lost. Tensile strength of the wound reaches 70 to 80% of normal by 3 months. Healing by second intention. Extensive tissue loss due to inflammatory ulcer or severe trauma is associated with extensive ingrowth of granulation tissue, accumulation of extracellular matrix, and scar formation. Intense inflammatory response occurs. Larger amount of granulation tissue results in more fibrosis, and wound contraction occurs within 6 weeks due to myofibroblastic activity. Effects of blunt trauma on the conjunctiva. Subconjunctival hemorrhage, which may result from direct ocular trauma or from head trauma. Conjunctival lacerations or conjunctival chemosis. Effects of blunt trauma on the cornea. Corneal abrasions. In corneal ulcer, there is loss of epithelium with intact Bowman's membrane, and fluorescein stains the epithelial defect. Recurrent corneal erosions shows defective epithelium junction to basement membrane. Mild trauma as fingernail scratches or opening eyelids precipitate minute corneal ulcers. Descemet membrane rupture follows birth trauma. It is unilateral, affecting the left eye. It takes a diagonal orientation, and a gap is seen in Descemet's membrane. Endothelial fills the gap, forming a new Descemet's membrane. Full-thickness corneal lacerations result in ruptured globe or iris prolapse. Corneal blood staining. Red blood cells infiltrate corneal stroma. This occurs secondary to hyphema or persistent high intraocular pressure more than 48 hours. It ends in slow absorption from periphery to the center. Healing of corneal wounds. Partial thickness corneal wound healing. Epithelial injury results in loss of underlying keratocytes secondary to apoptosis. Remaining keratocytes generate new glycosaminoglycans and collagen. Epithelial sliding and mitotic proliferation followed by epithelial reorganization occur within few hours. Limbal stem cells undergo mitosis, slide over basement membrane to fill the wound. Hemidesmosomes and anchoring fibrils form and, despite loss of Bowman's membrane, attach epithelium to stroma. Bowman's membrane loss results in haze formation, which is greater with deep wounds and prolonged epithelial loss. Total loss of corneal epithelium is associated with filling of defect by conjunctival epithelium within 48 to 72 hours. This conjunctival epithelium changes morphologically to corneal epithelium over the next few months. Full-thickness central corneal wounds healing. Being avascular, no granulation tissue formation occurs. Stromal lips swell and the wound gaps anteriorly and posteriorly. Descemet's membrane retracts and curves inwards with formation of a fibrin plug. Anterior surface reepithelializes. Epithelial plug fills anterior wound gap. Fibroblasts enter and elaborate collagen. Endothelial migration with formation of Descemet's membrane occurs. Active phase of wound healing takes 4 to 5 weeks, and complete healing may take up to 6 months.
Refractive surgery wound repair. All forms of keratorefractive surgery depend on modulating or reducing wound healing described above. Incisional effects. Radial incisions result in flattening of both the meridian of the incision and 90 degrees perpendicular on it. The initial weakening of the wound is followed by permanent healing with replacement of the epithelial plugs with collagen and remodeling of the collagen to ensure stability and avoid long-term hyperopic shift. Alloplastic material addition. Intrastromal corneal rings placed into the corneal periphery to alter the contour of the cornea. Used to flatten central cornea in mild myopia. Induces peripheral corneal stromal tissue compression and thinning. Migration, extrusion, and infection may occur.
Laser tissue effects. Photoablation, excimer laser. Laser energy more than 4 eV per photon breaks carbon-nitrogen or carbon-carbon tissue bonds, but has low tissue penetrance. In photorefractive keratectomy, PRK, the use of steroids in a tapering manner following surgery results in decreasing haze formation and stabilization of surgical effect. In LASIK procedures, the following occurs. Formation of a lamellar flap results in no haze formation due to the lack of significant epithelium disruption and maintaining intact surface neurons. No healing occurs between disrupted lamellar flap and stromal bed. Initially, the lamellae are held in position by negative stromal pressure generated by endothelial cells and held by an intact epithelial surface. Typical stromal healing occurs at the wound periphery. Aberrant healing occurs with flap malpositioning and growth of epithelium at the interface. Epithelium at interface acts as a barrier to nutrient flow and results in thinning, inflammation, and visual axis obstruction. Interface debris results in inflammation and light scattering. Effects of blunt trauma on the sclera. Rupture globe. Rupture globe constitutes 3.5% of severe blunt trauma. It has various sites: between limbus and rectus insertions, supranasal and supratemporal quadrants between the corneal limbus and equator, up and in as sclera is pushed against trochlea. Scleral rupture may be concealed due to severe periocular chemosis, subconjunctival hemorrhage, or intraocular hemorrhage, hyphema. Low intraocular pressure, less than 5 mm mercury. Deep anterior chamber. Inability to visualize fundus details, or vitreous streaming towards rupture site. In large posterior ruptures, poor visual acuity occurs. Effects of blunt trauma on the iris. Traumatic miosis, traumatic mydriasis, lacerations, iridocyclitis, traumatic aniridia, iridodonesis, iridodialysis. Effects of blunt trauma on the ciliary body. Ciliary body shock, hypotony, ciliary body dialysis causing angle recession glaucoma, or cyclodialysis, where there is displacement of the entire pars plicata and meridional muscles free from sclera. Effects on accommodation. Spasm resulting in index myopia or paralysis causing blurred near visual acuity. Ciliary body bleeding causing hyphema. Effects of blunt trauma on the lens or pseudophacus. Subluxation showing incomplete zonular rupture, monocular diplopia, astigmatism, accommodation loss, and iridodonesis. Dislocation showing total zonular rupture. Anterior dislocation results in pupillary blood glaucoma, whereas posterior dislocation causes phacoanaphylaxis or pupillary blood glaucoma by prolapsing vitreous.
Traumatic cataract. Anterior and posterior subcapsular cataract. Opaque cortical sutures with characteristic rosette-shaped cataract. Phocis ring, iris pigment epithelium impression on anterior lens capsule.
Rupture of lens capsule. Small ruptures are sealed with overlying iris or proliferation of lens epithelium, whereas large ruptures either cause cataract or lens material leakage into the anterior chamber causing phacoanaphylactic glaucoma. Effects of blunt trauma on the anterior chamber. Hyphema. Hemorrhage results from ciliary body vessels or iris laceration. Hyphema may be complicated by rebleeding, secondary glaucoma, either due to mechanical angle occlusion causing open-angle glaucoma or organization with peripheral anterior synecdoche formation. Other complications include corneal blood staining, hemophthalmos, hemosiderosis, and cholesterolosis. Effects of blunt trauma on the vitreous. Hemorrhage, liquefaction, vitreous base detachment, or posterior vitreous detachment, the so-called PVD. Cholesterolosis, or synchisis scintillans. It follows vitreous hemorrhage and is common in men in 5th decade. It is unilateral. Cholesterol appears as glistening brilliant yellow crystals that settle inferiorly with gravity and move the movement of the globe. It may incite foreign body granulomatous reaction. Vitreous hemorrhage. Blunt trauma is associated with vitreous hemorrhage in 18% of the cases. Vitreous hemorrhage results from ruptured ciliary body, retinal, or choroidal vessels. It has various forms, either subhyaloid hemorrhage, diffuse hemorrhage, or it may be associated with retinal tears. Effects of blunt trauma on the choroid. Choroidal rupture. Tear occurs in the inelastic Bruch's membrane, the choriocapillaries, and retinal pigment epithelium, whereas neurosensory, retina, outer choroid, and sclera are intact. Choroidal rupture may occur posteriorly around the optic nerve as yellowish-white line with retinal pigment epithelium atrophy or clumping, or it may occur anteriorly parallel to the ora serrata. Visual prognosis depends on associated hemorrhage, commotio retini, pigment epithelial contusion, and foveal involvement. Healing of choroidal rupture. Fibrovascular proliferation, fibrous scar formation, and retinal pigment epithelial hyperplasia occur. Healing process is complete in 3 weeks. Choroidal neovascular membrane, or CNVM, develops months or years following the initial injury. Most choroidal neovascular membranes regress spontaneously. Chorial retinal anastomosis may follow choroidal rupture. Effects of blunt trauma on the retina. Commotio retini, Berlin's edema. Results from Contrecoup effect within 24 hours after blunt injury to the globe. The outer retina shows gray-white discoloration. It affects the macula, causing cherry red spot, and may affect peripheral retina as well. Retinal whitening resolves in 4 days up to 4 weeks of injury, as the outer photoreceptor segment regenerates. Central vision loss may be permanent due to retinal pigment epithelium changes and migration, macular hole formation. Histopathology study shows disruption of the photoreceptor outer segments, acute damage to the photoreceptor cells, pigment migration to the ganglion cell layer, thinning of the outer plexiform layer and outer nuclear layer, and loss of the photoreceptor outer segments. Commotio retini or Berlin's edema is not a true tissue edema, as there is no evidence of intracellular or extracellular retinal edema fluid collection. Macular hole. Macular hole may follow blunt trauma due to the following mechanisms: contusion necrosis, subfoveal hemorrhage, or vitreous traction. Traumatic retinal tears, dialysis, and detachment. Traumatic retinal detachment constitutes 15% of all retinal detachment in younger patients, and the male-to-female ratio is 4:1. Traumatic retinal tears, dialysis, and detachment may occur by direct or indirect mechanism. The direct mechanisms occurs when there is anteroposterior compression with secondary equatorial expansion and vitreous-based traction. Vitreous-based avulsion results in retinal tears at posterior vitreous base and retinal dialysis. Direct necrotic irregular tears occur secondary to focal necrosis at the site of impact. The indirect or Contrecoup injury results from shock waves directed to a distant location, leading to a macular hole. Head injury without direct eye impact are unlikely to result in retinal breaks. Types of retinal tears: retinal dialysis, joint retinal tears, retinal flap tears, tears in an area of lattice. Effects of blunt trauma on the optic nerve. Optic nerve avulsion. Presumed mechanisms include extreme rotation and anterior globe displacement, sudden marked increase in intraocular pressure, leading to expulsion and rupture of the lamina cribrosa, shearing trauma tearing the pia of the optic nerve, direct injury of the intraorbital optic nerve by a missile or knife, total avulsion following severe orbital trauma, or partial avulsion following minor trauma. In optic nerve avulsion there is total or partial lack of the optic disc with associated hemorrhage. The partial avulsion may mimic optic nerve pit in appearance, serous macular detachment, rupture at the margin of the optic nerve and Bruch's membrane, and gliosis close the defect within 4 to 8 weeks.